Greetings, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to inform our audience, but also unearth successes, or what we call bright spots, at health plans, hospitals, and other healthcare-related organizations across the nation. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. Our topic today is around last mile care. Specifically, the title is Plan and Provider Strategies for Last Mile Care. I know we started for our live audience about 90 seconds tardy, which is very unusual. We're having some technical issues getting a couple of our guests into the show, into Zoom. So that was the reason why, and we're going to start without them, and hopefully they will be joining us as we get our discussion going. Today's episode is brought to you by our friends at the Partners in Care Foundation. If you have not heard of them, Partners aligns social care and healthcare to address the social determinants of health that routinely affect diverse, underserved, and vulnerable populations. Their latest innovative tool is called HomeMeds 3.0. It's an evidence-based platform for identifying patient medication-related errors. I will tell you more about the foundation and HomeMeds later on in the show, but in the meantime, if you want to check them out, you could check out the foundation at www.picf, Partners in Care Foundation, picf.org. Also, if you haven't subscribed to this podcast, right now, while I'm talking, grab your phone, go to Apple, Spotify, Google Play, whatever you use to listen to podcasts, and type in Bright Spots in Healthcare. Our avatar, my little face will pop up. Please click subscribe. Every episode we do live drops within the podcast feed within 24 hours. I'm also doing some record-only episodes. I'm going to be recording an episode with the president of Landmark Health and recording another episode with the CEO of Parkland Community Health Plan, both the next 7 days. They're both going to be dropping this month. So if you want to catch all that content and all those episodes, please do so by subscribing to the podcast. And if you've listened to this show a few times and you do appreciate the content, please do give us 5 stars and even write a little comment. It's not so much for the ego. It's more because this allows others to find us more easily with the more ratings and the more comments. So thank you in advance if you do that. Speaking of live episodes, our next live episode will be September 22nd. That's Thursday, September 22nd at 12 p.m. on the East Coast, 9 a.m. on the West Coast. And if you don't want to go through the registration process and just want to join us, the topic is on redetermination. If you want to come to that episode live, we will pre-register you. So we're going to put up a quick poll. If you want to come, boom, just click yes, and our team will pre-register you and you'll be way to go. All right, we're going to get started now. I want to start with the novel and the innovative. As we think about approaches to maximizing revenue opportunities and avoiding costs like unnecessary admissions or readmissions, I want to talk about the ingenuity that this pandemic we're all going through, what ingenuity has been as a result of the pandemic. So I'm going to bring in Rhonda Weiring. She is the Vice President of Clinical Innovation at Avera AtHome in South Dakota. Rhonda, what innovations have come out of the pandemic for your organization?
Yep, thank you very much for inviting me. A ton of innovations have come out of the pandemic. So during the pandemic, our Avera AtHome company who also runs a care transition service was contracted with the hospital to help with COVID care at home. And we discovered we had a very effective virtual care program that cared for over 9,000 patients very successfully with a very low emergency room and hospital rate. So successful, in fact, that our hospital leadership then wanted us to expand it more. And when CMS opened up the hospital at home waiver back in November of 20, we took advantage of that and then became a provider for hospital at home. And so one of the things that we learned through that was that to a lot of times you think like this is something we can't do. So we were able to think about like what are our strengths as a company and what can we bring to the table and tweak and innovate and then make a difference. Our COVID program was so successful that we reached a peak in November of 20 with 1,400 patients on our average daily census. So we knew that we had the capacity to do this innovation and create this model. One of the things that is where this has really helped our hospital system is now that we have the CMS waiver approved, we're able then to increase our bed capacity. We're in a rural area of South Dakota, and it's a tertiary care center. So we have a lot of times a big waiting list of patients for acute beds. Well, if my team can take those lower or lesser acute patients at home, provide them with their acute stay at home, then get them enrolled in home health, that saves bed days for the hospital. So we've also had great outcomes with patient satisfaction. They don't have the noise of the hospital. They sleep better. Great outcomes too with very low medication errors, very few falls, low readmissions. We have a nurse practitioner led model whereby the nurse practitioner goes to the patient's home, followed with nursing visits every day and physical therapy, all the things that a hospital provides. And the key part is that it has really freed up our hospital beds and been a good thing for us.
Okay, so that's terrific. So you have the nurse practitioner going into the home,
Right.
You bring in PT if necessary, and besides the cost avoidance, you are also freeing up beds that could be for higher acuity.
Absolutely.
And stronger DRG payments and all that, right? If I'm catching it.
Absolutely. And then at the same time, we don't have the same kinds of complications that you often see when someone's in a hospital. So patients are able to move about more. So I think that makes a huge difference in their ability to recover well.
Perfect. So Dianne, and just I'm going to introduce, by the way, I usually always say this, we could provide a link to everyone's full bios who are on the show today. So you could kind of tap into their expertise and understand their perspectives, and they've got all great experience and expertise here. I'm going to bring in Dianne Davis. She's the Vice President of Community Wellness at the Partners in Care Foundation. Dianne, can you provide another example of how a health system may be working to reduce at-risk incidences? I know that Rhonda just mentioned, reduction in medication errors and falls. Let's talk about medication errors and falls. Like how are large hospital systems executing on that?
Yeah, sure. So we've been at Partners, we've been working between social care and healthcare for about 25 years now. And we know that about 80% of healthcare actually happens at home, right? Things that affect health. So we believe, oh my goodness, my voice.
It's quite all right. It happens.
I know. It's happened before, so I know it happens. So we believe that everyone should really be working at the top of their license. So we work with this large hospital system. We actually work with a couple of large hospital systems here in Los Angeles, but one in particular that I'm thinking of now, it has 6 hospitals. And we have social workers that are located in the hospital. And when a patient is about to be discharged from the hospital, the social worker goes and meets the patient in their room, introduces themselves, and asks if it's okay for them to come and have a visit in the patient's home. And then, most patients, not every patient, but most patient will say yes to that. And so the patient will say yes. About 2 to 3 days later, we actually go to the patient's home and we do a full assessment in the home. And that's what we feel is really key, to have that VA social worker or a community health worker in the home, eyes in the home. They look to make sure that the patient is reconnected to their primary care physician, because sometimes that's the link that doesn't happen after someone's discharged from hospital. They also check to make sure simple things like that there's food in the refrigerator, because if someone goes home from the hospital and they don't have anything to eat, the likelihood of them being readmitted is pretty high. Another thing that they'll look at is, for instance, if the person's living in the San Fernando Valley of Los Angeles and it's 113 degrees outside and they don't have AC or their electricity has been turned off, that's also going to be something that's really going to cause them to be readmitted to hospital. And at that point, we'll work to get them enrolled in a program to cover the cost of the electricity, or we'll buy them through some sort of program an AC so that they can actually have, a reasonable temperature within their home. And then what we really think the secret sauce is a program that we have called Home Meds that we use in the home to do a complete medication check. So the social worker or the community health worker will sit down across the dining room table from the patient, or what was the patient, the client, we call them, and they'll take a complete list of all the medications the person takes. So we'll actually ask them, can you bring us all your medications? And they'll bring their prescription medications, their over-the-counter medications, and any herbals they may be taking. And during this, we'll also ask them a series of questions about falls, confusion, dizziness, whether they know how to take their medications properly, because a lot of times they don't. We had one instance where somebody was taking all of their medications in the morning, even though they were supposed to be taking, maybe one pill in the morning, one pill with lunch, and one pill before bed. And that can have a really negative effect on the outcome for that patient. So
and this is a large hospital system in California?
Yes, 6 hospitals in LA.
In LA.
Yeah.
And have you guys been able to evaluate the impact you guys make on these things? Are there studies that?
Yeah, actually, there is a study on this hospital system's patients that showed that they reduced their readmits to hospital by about 13%. And that can be equivalent to significant dollars. And it reduces suffering. And I work for a nonprofit, so I always really think about both the cost, the expense, and, how are people feeling? How are they actually doing? Like Rhonda talked about, by having the hospital at home. Well, it's the same kind of thing. If they don't have to be readmitted to hospital, that's a really positive outcome for the person.
Yeah, could we get a copy of that? Maybe we could send that to the audience. Get a
Sure.
copy?
Yeah, I'd be happy to send you a copy of that.
Well, why don't folks, if you want that study sent so you could see the impact and the methodology behind measuring that impact, it could be pretty useful. We'll send that out to you guys once Dianne gets it to us. So we'll put up a poll right now and just see if you want a copy of that. And
we also have a study with the same type of intervention with UCLA, and I can send you that one as well.
Okay. So you get 2 for the price of 1, everyone. That's great. Thank you for that.
Yep.
All right. So Mitchell Fong is the vice president of virtual care at Renown Health in Nevada. I'd love to hear from you on. And by the way, folks, if you have questions for Mitchell or Dianne or Rhonda, you could throw them right in the Q&A module. By now, everyone probably is familiar with Zoom, but it's in the bottom of your screen. And Sherry Kales and I will be monitoring that, and we'll be integrating those questions into the conversation. So feel free to help me co-moderate here and throw them in. So Mitchell, how is Renown Health leveraging at-home programs to reduce readmissions in Nevada?
Yeah, thank you for having me, Eric, and I appreciate the question. I'll say we looked at many different opportunities during the pandemic. Some of the ones that I'm sure are quite common around just using that direct customer virtual visit. So specifically for behavioral health, maybe not just preventing readmissions, but admissions was a big part of that, getting upstream to make sure those patients were supported before there were any further escalations in their health determination. So I think that was one thing that was extremely successful. But what we've looked at doing is bridging the discharge process to the recovery process. Particularly during the pandemic, we had capacity challenges, staffing challenges, and really the isolation was starting to have some behavioral health and mental health impact on the patient. So trying to get them home safely to recover in the comfort of their home was extremely important to us. And we launched a continuous remote monitoring program focused on pulse oximetry for COVID and respiratory patients. We saw great results with that, paired it with some partnerships in the community to make sure we can get those at-home DMEs, those community paramedic interventions when there were escalations to prevent readmissions. And then we used an infrastructure that actually had a pulmonologist overseeing the monitoring on the back end in partnership with our centralized monitoring team led by nurse leaders. And so with that combination, we're able to reduce the length of stay to safely discharge these patients sooner, but also as they're at home requiring oxygen support, continue to monitor them continuously, provide them the support in their home virtually, and then also provide further education to their caretakers, their family, and the patients, because we know that COVID fog was a thing. And so sometimes continue to remind them of how they can best manage their condition, and the support we can provide was extremely impactful. And so with those partnerships and the escalation process we had in place, we were really getting minute by minute vital readings on pulse oximetry, and we were able to intervene successfully. We've continued to expand that program since the onset of the pandemic to all respiratory conditions. And so we've had over 800 patients in total on the program. When we did a small cohort of just COPD to compare results, we actually saw about half the readmission rate that we saw prior to implementing this program. And so it was a really great success there. And with that, we're able to reduce length of stay by nearly a day for those populations. So for us, we felt like it's been extremely successful. Our NPS score is in the 70s from the patient side. And so that's been, to us, determination that the outcomes are what we're looking for. The satisfaction is there. It required that community connection, though, to make sure we can truly deliver that last mile care to the home. Because I think that was one of our biggest challenges, was how do we stabilize these patients? How can we address these escalations in real time when the patient's at a distance? And so we were able to find good partnerships with our local EMS and community paramedics to really assist with that.
That's great. Congratulations on that. I'm assuming, did you have any data on readmissions tied to home programs tied to pediatrics or neonates? That was a question from the audience. Or does anyone?
We do not currently for us. We were offering for adult populations, but we're actively exploring a pilot to actually offer that for pediatric populations.
Okay, great. All right, we're gonna. That was great. We're gonna move on. I did mention at the beginning of the show that I wanted to tell you a little bit more about the Partners in Care Foundation. So I want to spend a minute or two on that, and then we're going to talk about trust and building trust and programs tied to trust. And then we're going to eventually get into a blueprint on what some of all of our sort of, I'll say, our professors in front of you, how they would advise you guys in the audience to build a program. So we still have a lot to cover before the top of the hour. So the Partners in Care Foundation, they, as I said, align social care and healthcare to address SDOH that routinely affects underserved populations. And they really help serve that bridge between medical care and what a person can accomplish in their home. And they manage these gaps in non-medical care that affect a person's recovery and their overall health. And this includes challenges tied to food insecurity, confusion regarding medications, transportation difficulties, home safety, etc. And they partner with a network of community-based organizations and their own staff and coordinate and provide evidence-based services through this partnership. And they combine this human touch of caring individuals, CHWs, CHAs, and they combine that with innovative technology. And their latest product, as I mentioned earlier, is HomeEdge 3.0, and it's this evidence-based tool for identifying potential patient medication-related errors. The software has a proprietary algorithm, and it identifies hazardous drug interactions, any fall risks, or confusion related to possible inappropriate psychotropic medications, and any cardiovascular issues related to medication use. So it's a really powerful tool and a really combination of human and technology to make an individual's life a lot better. It's an evidence-based program. We're sending you those studies if you requested that demonstrate it improves quality of life, reduces cost, and just helps participants avoid suffering as well. They've been around since 1997. So if you haven't heard of them, it's probably just because you haven't been in their marketing aim, but they have been around for a while. They've been innovating and improving S2H solutions and driving life-changing, life-saving alignment between social and healthcare for people throughout our country. And they're doing great work. You could learn more about them and their team at picf.org. We're excited to have them as a partner to Bright Spots in Healthcare. So I had mentioned trust earlier, and we were going to talk a little bit about how important it is to stay local, how important it is that the conduits of your organization are part of the local community so that the local community really embraces your programs. And so when we think about the trust and the theme of and local, I'm going to ask Dianne to come back in and talk to us about how important trust is in reducing healthcare costs, and how do you at the foundation establish trust and leverage this to reduce the risk of adverse events.
Yeah. So I think trust, in any human relationship, trust is key. And, having been in the community, working in the community now for 25 years or close to 25 years, that's a key piece of the work that we do at Partners. And then I think after you develop that trust, or perhaps the way it's developed is, you talk about doing some kind of an intervention like care transitions or care transitions with home meds added. And you show success, right? And so by showing success through data collection and through, the kinds of studies that you're going to be sending out to folks if they're interested in them, that just builds on that trust. And so what we've seen is that our organization has grown, like in the last 4 or 5 years, astronomically, as some of the incentives around on a national basis, as some of the incentives start really heading towards paying for social determinants of health, which, we've been very upside down in the United States for a long time compared to, let's say, European countries in terms of what we pay for clinical care versus what we pay for care for social determinants of health. And unfortunately, I don't know, maybe I shouldn't say unfortunately, but they show better outcomes than we do. And, that's where that statistic I brought up, about 80% of care actually happens at home. That really is the case. And so we feel our secret sauce is that we get in the home. We take community health workers, community health advocates, bring them into the home. And a doctor's visit that a person normally has with a physician's practice, they're going to get 15 minutes if they're lucky of the physician's attention. And that's not, that's not putting physicians down in any kind of way. That's just the way the system has been built, right, for their expertise. But a social worker can go in the home, spend an hour talking to somebody, looking around their home and really seeing what kinds of changes perhaps need to be made in order to make that a more livable space for them.
Dianne, that 80% stat you just threw out, is that the care that happens at the home?
So it's not care that happens at home, but it's like what you eat, the exercise you get. It's your lifestyle, right? Lifestyle choices. Those are all things that it's actually goes even beyond that. It's like your lived environment. Is it a healthy environment that you live in? Do you live somewhere where there's major pollution? Do you have mold growing in your space? And these are all things that we actually deal with in people's homes. We'll go into the home and we'll see that someone's a hoarder. And that not only can be a risk for a fall, but it also can be a risk for all sorts of vermin, can be living there, or the germs can be there. And so we'll actually help them, we'll get a company in there to help clean out their home and make it really into a more livable space. So there's a lot that we haven't really thought of in this country for a long time about that really does impact health. But you're going to have a lot more expensive hospital stays if you don't have those sort of simpler things taken care of in the home.
Understood. Keep on asking those questions, folks. As you can tell, we're getting to them and just throwing them right into the conversation. You're doing a great job helping me co-moderate. Also, PSA, in about 15 minutes, you're going to be getting another email from me, which is asking you for feedback on today's episode. It's also asking you for guidance on topics we should be covering in 2023, which we're more or less have every episode kind of locked in for the rest of the year, maybe minus 1 or 2 weeks. So we're really thinking about Q1 right now and planning out what we want to do there. And so would love your feedback on that. This feedback form, by the way, only takes 2 to 4 minutes, multiple choice to take if you haven't taken it before for us. And we look at each one and we evaluate each one. So thank you in advance for taking the time. We'll be sending you reminders throughout the rest of the week and next week if you do not complete it. So just, save your inbox, more emails from me and take it this afternoon. Incidentally, we are tentatively planning an executive summit roundtable in Boston next year. And we're going to ask your feedback on that because we'd love to get the right folks together for like a face-to-face roundtable meeting for a couple of days to cover their various topics in person. It's something we've been thinking about for 2 or 3 years. The pandemic obviously slowed that down. And so would love your guidance there as well. Okay, Rhonda, I want to talk about scale because you talked about earlier in the show, hospitals at home and your program there. And I'd love, as we think about building up this like foundational blueprint for everyone listening, I'd love to talk about how you believe programs like Hospital at Home are able to scale and what you're doing at your organization to enable this to be a seamless, scalable program. What are the foundational elements that allow it to be doable?
That's a good question. And so the COVID situation was probably different because we really were in an emergency, so we didn't have time to plan for months. We had to get this program stood up within a week. So we had to scale fast. And that the other thing that occurred at the beginning of COVID was, we had a lot of departments shutting down. So I was able to develop a labor pool. So going from 10 or 15 nurses to 100 nurses that supported that program. I could do that pretty fast in an emergency situation. So, but now we're out of COVID, right? So now you have, as you're developing scale, we create for example, Hospital at Home. So we have a staffing plan and we have figured out how many hours per day that we need for all of the various people that provide the service, from the medical director, nurse practitioner, RNs that provide the care. We have a runner that does a lot of bringing things to patients. We also have community health workers that are in our program too, that support various things that we identify. And so we've got that scaled based on our average daily census. So we know we've got the staff that we need to take the program. In the beginning, we went from 0 to 4 patients would be our average daily census. We had the staff for that. And then as we got bigger, then we had to hire another layer of staff in order to support those patients because we needed to provide a certain required level of care. So it was really a pretty simple staffing plan. I think the important thing is getting out in front of it because it does take time to recruit staff. The other thing that I think was an advantage for us is we're within a health system. So we're able to share some staff. So we've got some second job coding that occurs and cross training, and all of those things can really help you as you're growing a program. And that's been very helpful for us.
It's great. So the key is really to have a care transition program in place, have that care coordinator in place as well, and have those programs in place. And that just allows you guys to build on top of that and do more.
Yeah, that's totally right, Eric. The other thing that I think has been an advantage for us, and I'm sure Dianne probably feels this way too, is we have several other programs that support hospital at home. So our care transition service report supports it, our remote patient monitoring services, that's all integrated. So we're not building like separate teams to do various functions within our care delivery model. That would make it really unaffordable. So we are utilizing some of our current services, community health worker, remote patient monitoring, care transition team, home care. We share staff across the board, and that's made a huge difference.
Great. I want to go back to you, Dianne, and then we're going to bring Daniel in for the first time. So Dianne, there's a question. I think it was geared towards you. Dr. Stratford asks, how do the social workers interact with the community health centers and the primary care doctors, and how many community health centers are implementing sort of patient navigators? Or no, she makes the comment. I beg your pardon. First part's a question. Second was a comment. Many community centers are implementing patient navigators.
So can you repeat the
How do
question?
social workers interact with community health centers and PCPs?
I mean, I think it largely depends on what their role is, but if we're talking about social workers acting as community health workers, they're part of the team. They're part of the patient care team, and so they just have a different piece of the work. Their piece of the work is more out in the community, right? Out in the home, out at community centers, places like that. But if there's some sort of what do they call it? Like, where the whole team gets together, they're a member of that team, and they'll talk about the patient at that team meeting. They'll, give their input, and in the best of situations, they basically are treated as an equal member of that team. I mean, clearly, the physician and the nurse are going to have the clinical oversight, and they're going to be the ones that are going to be reviewing any plan, perhaps, that the community health worker has developed with the patient. But I think, again, what this kind of situation does is it allows everyone really to work at the top of their license, which is I don't know about the rest of the country, but in California's job market, we're having a very hard time finding nurses, finding doctors, and even finding, community health workers. So we want everyone to be really working at the top of their skill set.
Great. I know there's some other questions coming in the queue. We will get to them. I believe there's a couple of good ones, but I want to circle back to the trust topic, because we've got here now Daniel Rivas. He is the senior manager at Blue Shield of California, and I want a payer perspective. And we were talking about trust earlier, Daniel, and I know when we had talked a few days earlier in preparation for this show, you had a couple of interesting examples of how Blue Shield was not only approaching partnerships with CBOs, but also examples of organizations that you've worked with around trust. So why don't you tell the audience a little bit about how you guys approach last mile and what's important to drive success, and then a little bit about your Trusted Messenger program.
Yeah, thanks, Eric. Thank you for the invite. One of the things we realized early in COVID was that as we're trying to help and reach our members and engage our members, it was tough because there was isolation. We were removed from direct contact. So we were looking at every communication channel we had to engage our members. And what we ultimately realized is that the emails weren't being opened, the calls weren't being answered. And so we really had to shift and look at what else do we have available that is going to really impact our communities and reach those members. And what we realized is this is a best practice that has been going on for a while, and it was a trusted messenger. It was the popular opinion leader, the gatekeeper, and intervention that I think has been used for through many projects. And so we shifted and said, who do we know? Who do we have relationships with in the community that are already building content, that are already boots on the ground, working with these communities? And one of those examples is a project with an FQHC, a federally qualified health center, Herald Christian Health Center in San Gabriel Valley. They were specifically working with the Chinese community. And what we did with them is we helped provide some capacity building support in terms of small funding, but also connected them with a platform that helped amplify their communications with their members and create a two-way engagement. So Herald Christian was able to send messages out in various formats, so they could create flyers, send them out rather quickly in a text. They could create videos, and ultimately they were also able to create campaigns that connected them to appointments on the spot. And we created a campaign with them to increase well child visits. So we communicated through our provider engagement team a list of members that hadn't had a well child visit in about a year. I think 12 months was our period that we were looking at, and worked with Herald Christian staff to reach out to those members and also open up appointments through that platform.
So this is a Herald Christian Health Center, is a federally qualified health center located
in San Gabriel Valley. So there's different areas, which is high API communities, different languages, and it really worked because they were able to send out those messages in Cantonese and Mandarin, English and Spanish as well.
Perfect. I just want to get the lay of people to get the lay of the land so they could picture it. That's great. And you had another one I wanted you to share with us.
Yeah, there's the CalPERS. So this was early 2020. We were trying.
And I'm sorry, Daniel, because not everyone's from California. Tell everyone what CalPERS is.
Oh, CalPERS is the California retirement system for state employees. I forget the acronym right now, Eric. Sorry, I apologize. But so it's California's retirement system, and one of the projects we took on early on was how do we address trauma, behavioral health barriers and challenges within our first responders. Little did we know it was going to become such a big need during COVID. So our first population, our first group that we tried this out with was the California Firefighters Task Force, the firefighters. And so we partnered with the California Behavioral Health Task Force to create a program that supported first responders or firefighters dealing with trauma, because we know they have high rates of substance use, suicide. And it was very important for us to make sure that our providers, or we were figuring out ways to facilitate access to care through our provider networks, but also supporting the firefighters where they live and work, which is their firehouses. And it was tough. I'll tell you, it was really tough because that is a very protective population and protective community, which we'll see in other communities as well. But there's so much stigma associated with mental wellness, behavioral health services, because anytime there's a mention of a need for behavioral health in this population with the firefighters specifically, you become a liability, right? Are you capable to serve in the position if you have a behavioral health issue? What we realize is we couldn't come in as outsiders and say, here, let's give you this training, let's send you to these services for more support. It really was working within their system, which already had curriculum created that they were sharing with each other, so that it was a train-the-trainer model. It was promoting the curriculum created by firefighters to support firefighters, and ultimately figure out how they could seek support without the risk of being seen as a liability or a risk.
I love bottom-up approaches like that. Those are the ones that often stick the most. Train the trainer is a concept that is a bottom-up approach that often works really, really well. Love those two stories. Glad you were able to share them. So here's what we're going to do. We're going to cover in the next 15, 20 minutes or so. We're going to talk a little bit about the blueprint. We're going to talk a little bit about how Blue Shield of California measures the impact of these programs as well. But before we do that, I want to bring back Mitchell Fong, because I want Mitchell, can you talk about a program, how you go about ensuring a program like your continuous remote respiratory monitoring program? How do you ensure that it works? Like, how does it, you ensure that once you invest in the infrastructure and launching it, that it actually achieves your business and clinical quality goals?
Yeah, great question. I always say you have to have the end in mind. So you start with your core metrics that you're tracking for outcomes, but then you need to have guardrails in place and checkpoints for your reviews with all the key stakeholders. And so for us, guardrails were safety issues, technology issues, access, any inability to see the positive outcomes. Obviously, we were measuring the outcomes I referred to earlier. So we had those guardrails in place up front that we knew we were going to track. And if we ever got out of sync with the targets, we were going to pause, take a look at what we're doing to ensure that we are refining the program and continue to improve it to get that outcome. And so with that, we put in place some of those guardrails around experience and quality in particular. And I think that was extremely important for us to track that in real time, but also continue to meet. And so the cadence for our team when we first launched was twice a week. We were meeting every Tuesday and Thursday, 30 minutes with every key stakeholder team, checking in on what are the issues coming up, what are the barriers, what are the burdens, what is working, what's not, and let's continue to brainstorm and improve that. After we got relatively mature, we went down to once a week, and then now we're at bi-weekly checkpoints because we feel the program is further along now than before. But really having those key stakeholders there so that there's concrete action items that can be addressed timely to continue to evolve the program were extremely important. But then having that continuity of collaboration with those partners, some of that was DME response time, delivery windows, getting it to the patients timely if we're going to discharge them. And similarly, having those same quality checkpoints in place that you would have to deliver parity care, at least the same level of quality as you would have in-house. And so, for example, for those COVID patients, when we were monitoring them, we had them do what you would call your 6-minute discharge walk test in place in the facility. We would do that over the camera on a Zoom visit. Or we would do the arm flail for 2-minute test, very similar, but to test the respiratory capacity with no oxygen support to ensure we can have a safe discharge. And so putting those systems in place to ensure you're having the same level of quality care and then continuing to monitor them throughout was something that was extremely important. And I always like having clinician care team as well as patient surveys, because I think that the feedback we got, the recommendations for what could be better, a lot of those are things we implemented right away, same week, same day almost, depending on the feedback. And that really helped us ensure we were continuing to evolve and meeting those core metrics. So for me, I think those were the big picture things that we put in place up front. But with that structure comes the training, the support, the testing, the real-time access for your technology team to provide that support, having people call patients to walk them through the setup if they get disconnected, or help re-educate them on the technology, meeting with their families virtually to do the same thing and re-explain what the program is, how they could help the patient. Those were things that were extremely important. We created QR codes on the patient handouts so they can watch it as a video, as well as read through the content, because we know some people are more visual learners. So having that different enablement, literature in multiple languages, translation there, those were things that were extremely important from the foundation of it. But obviously for sustainability, you have to look at what's your cost, what's your ROI, how am I getting reimbursed, what are the codes that we're using, am I doing it compliantly as well, just so we can continue to scale the program and keep it sustainable. So those were some of the things that we kept in mind as we built it and sustained it.
I want to double click on that, because the technology support, that basic blocking and tackling that happens at every company, right? Not just the hospital, and how to train someone on technology. You're doing that prior to discharge, now that we're, for the most part, right? And it's not necessarily reimbursable, right? You're just investing in that. Can you speak to that for a moment? Because I want to transition to ROI here, and I want to hear from, why are you guys spending so much time on non-reimbursable services here?
Yeah, definitely. From the inpatient stays, we do the setups prior to discharge because we think it's a better experience for the patient. We also think it'll be more successful knowing that we've set them up, we've educated them, we've trained them on the device, we know it's working before we send them home. But doing that in the inpatient stay, to your point, does make it not reimbursable for us. It gets looped into the DRG payment. And so it's part of the inpatient care with no additional revenue. But we thought that was the better way to be successful for the quality, the better experience for the patient, particularly those that need that oxygen support. You don't want them running around, going to different places to get that set up. So that was extremely important for us. But that's also why we had those checkpoints of metrics where we had to look at, are we improving length of stay? Are we improving readmissions? Are we safely graduating these patients from the program? Because then those investments of time for the upfront setup, while not being reimbursable, they're paid in fruits at the end with the outcomes that we're able to influence with the decreased length of stay and readmission. And so that's how we're looking at that. We still can get paid and do on the monitoring aspects, but that setup and that technology are what we don't get reimbursed for because of the model that we have for that setup prior to discharge.
Right. Yeah, I love that. I love that because that just shows how innovative you guys are thinking. You're not just kind of going down the map as you've been told and thinking, okay, we get paid for this, so we have to do that way. How does shifting gears to health plans? And I'm going to bring back Daniel Rivas, and he is, as a quick reminder, he is the senior manager at Blue Shield of California. How are you guys at BSC measuring the impact of your last mile programs?
Thanks, Eric. Very much like Mitchell, we're looking at not only what we're spending on and how little we're spending on, but also where our savings are, right? Prevention. And so those are some of the pieces we're looking at as to the projects and outcomes that we're trying to measure. I think engagement is important, and sometimes we have to look at things differently, especially when we talk about engagement and what we've done in the past. With one of the projects we did, where we were COVID specific, trying to reach our populations most at risk and most impacted by COVID. It wasn't just about getting them the information, right? Because we knew a lot of people had the information, but we knew that if we could get a vaccine or get them vaccinated, we were probably saving on hospitalizations. But we also looked at the engagement piece of that campaign, and in terms of how many languages were we reaching, how many languages were we able to create campaigns around, and then how many other related issues did we touch on connected to COVID-19. So it wasn't just about vaccinations, it wasn't about hospitalizations, it was about those issues, those health issues that are connected, because we saw during COVID a decrease in colorectal cancer screening, breast cancer screening, and well child visits, so pediatric vaccinations. And those were ultimately important for not just us as a payer, but the communities that were impacted by not getting vaccinated or not getting screened. And if you want to look at it from a business perspective, if we can screen early, those are cost savings in the future and improved health outcomes. Most importantly, right there, that we have healthier and longer lives for our members when we get them screened early. Sure. So those are the pieces that we look at, and it's not always like how much are we spending up front on, but how much are we saving also? For example, with the COVID vaccine campaign, we realized with every vaccine we got, potentially that's about an $8,000 per person savings in a hospitalization that we had. And that's huge if we vaccinated 880. So that was important for us as well.
Daniel, when we met earlier, I thought it was really interesting to just learn of the matrix style of how you guys think about this. So, and I know you just explained it, but just to put sort of something in everyone's mind's eye, I know we're not using slides here, so we'll have to just explain it. You had you mentioned language, campaign, and engagement, but you're creating a matrix kind of view of it with the program's reach, their impact, and the efficacy. So I'm wondering if you could just lay that out very quickly for the audience so they can understand how you guys look at it.
Yeah, I mean, I like to use Herald Christian Health Center because that was one of our best practices or best partnerships that we had, where again they were able to look at languages. They had different languages that they were able to implement rather quickly. But what we found out through this platform that they were using and their efforts also was that we could address many other issues that were again supplemental to the COVID-19 project, like colorectal cancer screening. And for example, we had 37% of the target population engaged in care program from those that we started to reach. So that engagement turned into action and actual care for those members. I don't believe that was thousands of people, but still significant amount. 30% of those that they reached were able to get into care. So that was very impactful. And then when we talk about food inequity and social needs, we were able to assess for the need of those individuals that they were reaching out. Even though it was COVID, they still were able to support those families by addressing the immediate need, which sometimes wasn't COVID. It was, how do I pay rent? Do you need legal support for evictions, or do you need help with food?
And do you guys also, regarding early detections, and this isn't a message from it's a question from one of our audience members. Do you engage members by sending at-home tests? Let's say for colorectal.
Yeah, that wasn't part of this effort. I believe we have that option, but that wasn't part of this campaign. I think that's a great thought to incorporate into next initiative.
Okay, I'm going to bring in now. We're going to turn to all professors. We're coming in tight on time. I'm going to bring in Professor Davis here.
Eric, can I say one thing about the at-home test?
Yeah.
So, I think that's a great idea. I think there's a lot of challenges, and where I think the community health workers, or for us, the community health advocates, play a real important role, because a lot of our community members, you have to deal with stigma, especially if you have colorectal cancer screenings, about how to take it, and just the ickiness of our members feeling confident enough to take that test. So, I think in collaboration with a home visit, community health worker, I think home tests will work, but I think we still have a lot of education and support to provide to our members before that can be a successful approach.
Got it. Makes sense. So, Dianne, I want folks to leave here with a little bit of a blueprint on how to enhance or build, if they haven't yet, a successful last mile program. And so, what are some of the core components you would recommend to them that they must have in place? And as time has, I may go around a little bit and ask everyone else on the panel the same question.
Yeah. Well, you've probably already heard it, actually, from pretty much everybody here. And I just want to say that we've worked with Blue Shield of California quite a bit, and they're like fantastic partners, and they really seem to get like the importance of being in the home. And that to me is the core of everything. And everybody here has, talked about how these home programs have really worked well, and how much we've learned. The COVID pandemic has been horrible, but how much we've learned from it, and how much we've learned you really can do in the home. But I think getting those eyes in the home, making sure that people are connected with the services that they need, whether that's, food services, whether that's some legal help, like Daniel said, making sure that they can stay in their home, whether that means they need an air conditioner, or whether that means that they need to have a real deep dive into the medications that they're taking, like we can do with home meds. And, like I said, it's very surprising when you see, what's in people's homes. If we ask them to bring all their medications, I've had people literally bring like 30, 40 bottles, prescription bottles, like to the table, and they have meds all kept together that some of them can be like 10 years old, right? And they're not things they should be taking. They're things that should have been thrown away already, right? But sorting through that, making sure that they know how to take their meds, because a lot of people, I didn't know until a Blue Shield of California nurse called me up and said, take your thyroid medication every morning. Well, I'd been taking thyroid medication for 35 years and nobody had ever said that to me before. So these are things that, they're simple, they're not highly clinical. And I love the health system when it's needed. I've seen the health system do miracles on my kids and stuff, like clinical system. Thank God for antibiotics and for, nurses and hospitals when we need them. But a lot has to do with what's going on in the home.
Okay, so we need someone in the home. I'm going to use that as foundational piece number one. Anyone else want to add a couple things, or are there other things? Mitchell?
Yeah, I'm happy to jump in. I think education, support, and then technology enablement, validating all of those things. I'm assuming we think of last mile. A lot of us think of broadband initially. And so I think to deliver care in the home, we need to make sure the home is connected enough to support the technology, and that we're there to train as well as support in real time the technology working, so that we have a good experience for the care team as well as the patients. And then with that, I also always think, I'm a big data person. I think having the right data is important, whether it's retrospective, real time, trending with smart alerts. That's the way that we can be proactive with these patients that we don't physically have eyes on. And so I think it's very important that the technology works, the support is there, but we really have that foundation of success, is what I like to call it. Because when a patient comes to a health system, when they're in the hospital, what they feel is, I'm wrapped in a blanket of comfort. I'm wrapped in support. I don't have to worry about anything. And I think that's the big challenge for patients and families to feel comfortable taking care of the loved ones at home, is how do we give that same sense? Or how do we as family members or caretakers make sure we feel that security of having that support? So I think the enablement and the education is extremely important.
Diane, I don't want to sound too commercial here, but like that's essentially what Home Meds does, right? It allows a health plan and a health system to have all of those alerts and information.
Well, it allows, so we have in version 3.0, we have APIs, so we can actually connect to Epic. We could connect to, a Cerner program, something like that. So it could be that there is an actual direct connection between the whole Home Med system and a health systems. I just want to talk about something that Mitchell said that I think is super important, because I run another full set of programs that are run off the internet, and actually Home Meds is as well. It's a cloud-based program. You go into the home and put everything into the system right there while you're sitting across the table. But so many homes in low-income areas, which is primarily where we work, they don't have internet, and for older adults, perhaps even more importantly, they've never used a computer. They're afraid of computers. They're like afraid to deal with it. And it's a huge, huge issue. And thank goodness, that there seems to be a lot going on in California and nationally around making broadband more available and at a less expensive cost to people that are in those low income. It's a big issue. I know Rhonda probably has experienced that because it's in rural areas. I know it's a huge issue as well. So, I think having that broadband is really important. So kudos to you, Mitchell, for bringing that up.
I see the time here, so I want to be very careful because, as everyone knows, I'm pretty obsessed with making sure we start in at a time. So I want to thank all of you for all the hard work you put into preparing for this and for your participation today. I saw also a lot of answering of the Q&A through chat, which was or through typing. So thank you for that as well. We didn't get to every question, we got to most of them. And for everyone who took the time out of their day today to listen to the show, whether you're listening live or recording, we don't take the hour you spend with us lightly, and so we appreciate it. We like putting together material for you to help you, and I always like ending the show with, this is your Bright Spots in Healthcare podcast. So thank you very much, everyone.